Okay, hey, EKG enthusiasts, let's get started today. This is your Unit 1, Lesson 3 um, video, and we are going to start matching the leads to the different heart regions that we learned last class. So this is your video lesson that goes with your notes. I have my notes right here. I'm going to pop these up every now and then. This is what it says right here on the notes. You should have the same ones. Unit 1, Lesson 3, matching leads to heart regions. So if you have not printed the note sheets out, you need to pause this video and go print the note sheet. You should also have done Lesson 2 already before you start Lesson 3. It won't make much sense if you don't do Lesson 2 first. So make sure you've done Lesson 2 with your note sheet before we get started today. All right, so if you've got all those, check those boxes off, you're ready to go. Let's rock and roll. All right, so like I said, be sure to print out the notes, follow the lesson, be sure to view, blah, blah, blah. Yeah, here we go. All right, so what we learned the other day was that lead 1 went from the right arm to the left arm. Lead 2 went from the right arm to the left leg, and lead 3 went from the the left arm to the left leg. Okay, so these coincide with a certain different regions of the heart. You can see the heart here, and we have our heart kind of broken up into different parts. I'm going to move my face up here so you can see my screen a little bit better. So across the top of the heart, near the top, I have this up here. This is considered the lateral region. So anything that goes across the top and lands over here on the left arm is going to be considered lateral. So remember, lead 1 already, we know that goes across the front, right? So that's lead 1. Will be considered lateral. Across the top of the heart, any artery across the top of the heart here that has a blockage or something wrong with it will show a change in the leads that are considered lateral. We'll get to those in a second. Then, of course, anterior. Anterior is exactly what you think it is the front of the heart. So this big meaty part in the front here, this big one right here, we have a coronary artery that runs down the front here. This is the anterior region of the heart. So any of these blood vessels here, if they're affected, you'll probably see changes in what's called the anterior region of the heart. Then we have the inferior. So inferior is going to be below. So that's kind of like this part here. Anything below, I know you guys want to think of this over here as the bottom, but this is the bottom. This is considered our apex, correct? We talked about apex. So we do have leads that coincide with the apical, or what's also called low lateral. All right, so we have lateral across the top, anterior is going to be across the front here. Inferior will be across the bottom, and apical or low lateral will be at the apex. So let's think about those leads we learned the other day. There were 6 of them, the first 6. 1, 2, 3, AVR, AVL, and AVF. Let's figure out where they go and what they mean. And we know what they mean, but let's see what the regions of the heart are that they match up with. All right, so let's start with lead 1. Okay, so lead 1, as we know, goes from the right arm to the left arm. So that goes directly across the top of the heart. So it's going to be considered lateral. Okay, so on your paper, I'm going to show you here in a second. I'm going to show you my paper. I have a paper just like yours. I'm going to slide it on over here so you guys can see it real quick. So here is my paper. It's really going slow here. Here's my paper. I have exactly what you have. Move my camera just a little bit. And on here on the first one, draw the arrows as seen on the PowerPoint. So the arrows that we've seen here, and the lead directions represent different regions of the heart. So our lead 1, so what I would like you to do is to draw the arrow across. Remember, lead 1 goes from right arm. If you want to draw your 4 little circles that we did the other day, you certainly can. So this goes from here to here, right? That is going to be lead 1. So draw this right on your paper. Lead 1 goes from the right arm to the left arm. Remember, this is the right arm. This is the left arm. This is the right leg and the left leg. You'll find out, as we did in the last class, you'll notice we don't really use the right leg because that is ground, correct? All right, so right arm to left arm is lead 1. And you can write that over here. What coincides with that is going to be our lateral region because it's across the top. So write lateral in here. Okay, So we're going to draw leads 2 and 3 as well. So let me just close this out real quick so we can see mine. Next one is going to be our lead 2, which if you recall goes from the left arm, the right arm, not the left arm, the right arm down to the left leg. So again, we're going to draw that one on our paper from the right arm down to the left leg. That is going to be lead 2. So label that lead 2. And then we'll also throw lead 3 in there just for fun. Okay. So lead 3 will go from the left arm to the left leg. Okay. There's our Einthoven's triangle. You can see right there. And notice we did not use the right leg. So the little squares on the side here that you have on your paper, you're going to write down that lead 1 is considered lateral. Lead 2 and 3 are inferior because they land at the bottom of the heart. I know it looks like it's apical. It's not. Apex is in the armpit. And this is kind of going past the armpit. It's going below that. Okay, so consider that not apical. It is inferior. So let me show you my picture again, of my notes. It's popping up. So as we go across here, I'm going to write down lead 2. Goes from here to here, right? And since it's going towards the bottom of the heart, that's going to be considered inferior. And notice that lead 3 also goes from the left arm to the left leg, also goes to the bottom of the heart, which is going to also be inferior. So notice that lead 2 and 3 are both inferior. So those leads on your EKG paper itself are grouped together. So we're looking for changes in the EKG. We're going to get to this in the next unit. We're just trying to prep ourselves for the next unit already. So the leads 2 and 3 are grouped together. So if I see a change in lead 2, I know you don't know what that change is specifically yet, but if I see something different in lead 2 that I'm not used to seeing, and I also see it in lead 3, then I know that we have a change in the inferior region of the heart. How is this helpful to doctors and physicians? It's helpful because then now they know that when they go in to look at the heart arteries, they can look down here at the bottom. That's where something's going on. It gives them a heads up kind of, okay? So make sure you've done all this with your paper, and we're going to move on to the next one. Pause again if you have, oops, that's full. We don't need that full, do we? My bad. Okay, so pause the video if you're not sure, if you need to go back and redo anything. So let's take a look at the next one. The next one is going to be, we have our leads, our augmented leads. That little A stands for augmented, if you recall, and V stands for ventricular. R is going to be our right arm. L is going to be our left arm, and F is going to be our foot. Okay, R, L, and F. All right, and if it's the foot, we don't use the right foot, so it has to be our left foot. And in coinciding with all of these. All right, so let's take a look at, this is AVL. So notice that augmented actually means that augmented means that we're using all 3 of the leads in Einthoven's triangle. So 2 of them are going to talk to each other first, and then they're going to send a signal to the third one. So in this one, since it's AVL, L stands for left arm, then the only other 2 leads we have to deal with, we have our right arm and our left leg. They're going to send a signal to the center and meet in the middle, and then send it over to the left arm. Okay, so this is AVL. And since it's landing on the left arm, over here, remember, it's pointing to lateral. So this is also a lateral one. All right, so what does that look like on my paper? Now, on your paper here, you have 3 different little hearts here. Let me just move it up just a bit. I have 3 hearts, 1, 2, 3, and we started with AVL. So I'm going to start here. This is going to be my AVL. And yes, the little A, the A is written lowercase. Okay. Actually, let me make this bigger so you can see it. All right, so the A is written lowercase. A V stands for ventricular. L stands for left arm. So remember, we only use these 3, our Einthoven's triangle. And since it's augmented, we need to use all 3 of them. We're going to land at the L, which is our left arm. So it's going to stop here. It's going to end here. So these 2 must first meet in the middle and then go out to the left arm. That's AVL. And we also learned that AVL is lateral, okay? Because it goes across the top there. Okay, let me make this small again. Because it ends over here on the left arm, just like our lead 1 did when it went from the right arm to the left arm. They're both considered lateral. All right, let's take these away. All right, next one is AVF. So again, we have 3 of the stickers we're using, right? AVF is going to be, F stands for foot. And since we don't use the right foot, it's going directly to the left foot. And that means the 2 arm leads must meet in the middle first and send the signal to the left foot. Okay, so this one will be here and down there, AVL. And again, let's draw that together. So this is AVF. AVF. F stands for foot. Since we don't have, we only use the left foot, it's got to land down here. So let's draw my 3 circles on here, my 3 leads. Since I don't use this one, I'm not even going to draw it. So it's going to end here. So that means these 2 have to first meet in the middle and head to the left foot. And since it's going to the left foot, that's way down below, that's inferior. Okay, so that is an inferior reading. Now look at that. We have 2 inferiors, 3 inferiors, 1, 2, and 3. And 2 laterals, lead 1 and AVL. And inferior are 2, 3, and AVF. So those are regions of the heart. So it's kind of like a double check, like check your work type thing. When we did the heart axis, it's double checking your work. So if I see a change again, if I see a P wave that's a P wave that's inverted upside down in lead 2, that's inferior. That means something's going on in the inferior leads. I need to check leads 3 and AVF as well to see if they also have an inverted P. Now, if 2 of the 3 have changes, it's considered a change and something's up. We got to take a look at it. If you only have 1 change in those leads, you have to have at least 2. If you only have 1, it's considered what's called non-diagnostic. It doesn't mean that it means nothing. It just means that person's normal. It's a little bit different than other people, but it's not anything to be concerned about. We have 1 more lead to look at. That's going to be our AVR here. Hold on a sec. Okay, so AVR, once again, the R at the end stands for right arm. Since we don't use the right leg, that's going to be right arm. And since we're landing on the right arm, we just use the other 2 leads that we have that meet in the middle and shoot everything out to the right arm. Okay. And notice it's going over here. We don't really have anything for a region of the heart that coincides with AVR because it's literally heading away from the heart. So it's not giving us any heart issues or heart time. There's no heart arteries over here. This is the right atrium, actually. There's no heart arteries over there to worry about. So it's not really used in this sort of like, let's see what's happening with a region. It doesn't coincide with any region of the heart as far as coronary arteries go. Okay, so let's look at the picture. Let's draw it on our paper again. On that 3rd little heart we have there, I'm going to use my green one. So this is AVR, and R stands for right. I'm going to do this on here. F stands for foot, which would be left foot because we don't use the right foot. And L stands for left arm. Okay, so right arm. Okay, so again, drew my 3 circles. They're my leads, my limb leads, right? We don't use this one because it's ground. And since I have 3 there, it's R. It's going to land on this one. This is the right arm. So these 2 must meet in the middle first because it's augmented, and then shoot their signal out to AVR. Okay, So this doesn't coincide with anything. None of the regions of the heart make sense with AVR. So we'll get into AVR a little bit more later, exactly like what it means and why. And remember when we did the heart axis, AVR was negative. It's just kind of a check, but it doesn't coincide. Like make sure I have the leads on correctly, and the heart axis and things like that. But it's not really used for any regions of the heart. Okay, so just the 5 really are. All right. Again, pause if you have a question. You're not sure. Go back and rewind it. We're moving on. All right. Let's talk about the anterior region of the heart. Now, this says leads AVR, AVL, and AVF. That is incorrect. These are not those leads. I need to make a change in my presentation. I probably will before I post this video. Anyway, so this should be leads V1 through 6. Those are, as you know, they're placed directly on the chest. 2 are here, and they work their way down through that Nike swoosh up into the armpit, right? And here they are right here. So this is basically where it's kind of placed on the heart. Your heart is center chest, but pointed to the left, so it's more going to be looking like this. So let's take a look at V1 first. V1 right here and V2. So V1 and V2 are there, and they are clearly anterior on the front of the heart. Now, I want you to think about where the septum is. So the septum runs kind of like right down here. This is going to be your right atrium and your right ventricle, and your left ventricle, much larger. Your septum actually runs kind of like this. So V1 and V2 are going to be on the right side of the septum. Still considered anterior region, just on the right side of the septum. Okay. And then we have V3 and V4. They are also considered anterior. We're still in the front of the heart, except they're going to be on the left side of the septum. And then 5 and 6 are the ones that are up in that armpit that are actually located where the apex is. Those are the only ones that are considered apical or low lateral. But they do get grouped together. If you have a change in one, you should have a change in the other. As far as these anterior ones, I know that we have V1 and V2, there's right septal and there's left septal, but they're still all considered anterior. So if you have a change in V1 and also a change in V3, that can still be diagnostic. Even though one's on the right side of the septum, one's on the left side of the septum. Still be diagnostic. They're all considered anterior. So it's technically 4 leads stickers on your body that are reading the anterior region of your heart. Okay, so let's do the picture together here. So I need to move it up again. All right, so we're down here. I'm going to draw my stickers. 1, 2, 3, 4, 5, and 6. So that's V1, V2. That's hard to see, isn't it? Maybe the blue one will be better. V1, V2, V3, V4, V5, V6. That's a little better. You can see that a little better. Okay, so think about the septum running right here. Septum. So V1 and V2 are going to be anterior. This is the right side of the heart. So anterior, right septum or septal. V3 and 4 are also anterior. They are just on the left side of the septum. And then 5 and 6 are going to be our apical, which just coincides with the apex, or low lat, what's considered low lateral. All right, so you got your notes all filled in there. So this is how those leads that we learned our lead direction, this is how they coincide with different areas of the heart. Now, why that's important is for the cardiologist standpoint is when they know something, say someone's having a heart attack, and we hook up the EKG machine and we can clearly see heart attack changes on the EKG, which is our next unit. And I see them in 2 and 3 in AVF. all the changes are in 2, 3, and AVF. I know now where I'm looking when I go to do a cardiac catheterization, when looking for blockages in their coronary heart arteries, is I'm going to look in the inferior region of the heart. So I'm going to look directly at the bottom here. It's got to be blocked somewhere down here. Okay. If it's changes in V1, 2, 3, and 4, it's going to be somewhere in the front here. So it might be in this artery here or one of these arteries. So the cardiologist knows exactly where to check. It's crucial. It saves viable minutes, sometimes life-saving minutes when you're dealing with someone having a heart attack. So EKGs are super duper important when it has to do with heart emergencies. All right, so let's move on. So what I think I have is I'm going to group them together so you can see how they make sense. So remember looking back at our notes, 1 in AVL, both went across the top here, right? Lead 1 went from the right arm to the left arm across the top, and AVL was left arm, so it landed here. It met these two in the middle and went to the left arm. So they're lateral regions of the heart across the top. So those two are grouped together. Now, if I see a change in lead 1, I must also see a change in lead AVL. And if I have a change in both, it's diagnostic. There's something going on. If I only have a change in one of them, it's non-diagnostic. Just kind of get those terms going in your head for now. Next ones is the 2, 3, and AVF, all inferior. And I'm pretty sure I showed those to you kind of before here. They are the inferior region across the bottom of the heart. Again, if I see a change in 2, I will also see a change in either 3 and AVF or all 3 of them. There at least had to be a change in 2 of the 3 for it to be considered diagnostic. Then we move to V1 and 2. Those are anterior right septal, V3 and 4, anterior left septal, and 5 and 6 are apical low lateral. Okay, so write all those down on your paper. Lateral region. I'm going to have some, I can see on your paper here, note sheets, it says Slattery's shortcuts. I'm going to get to those on the next slide, what the shortcuts are, so you can kind of remember, just kind of, easy way to remember where the regions are and how they're grouped together. Okay. So these should all make sense. Anterior, again, if you see a change in V1, you should also see a change in either V2, 3, or 4, or all of them. It could be 2 of the 4, 3 of the 4, or 4 of the 4. And once you have more than one in that region of the heart, then you have a definite change. It's considered a positive change. Positive in medicine, by the way, is bad. If you have a positive stress test or a positive EKG, a positive CT scan for cancer, that's bad. You want negative tests. Negative means everything's clear. Positive means, oops, we found something. Okay. So then V5 and 6, apical low lateral makes sense because V5 and 6 are literally placed in the armpit with that Nike swoosh, and it's going to be right at the apex of the heart. Naturally sits right there. All right, let's take a look at the shortcuts. So we've already got this stuff written in. If you haven't, you can catch up now. So I remember that 1 and AVL go together. L in AVL stands for left arm, but it also stands for lateral. So across the top is lateral and left arm. So it's laterally heading to the left arm, LL everywhere. AVL, 1 and AVL. We know 1 goes across. And 1, literally Roman numeral 1, looks like a lowercase l. That's how I remember that. So 2, 3, and AVF go together. We know they all land at the foot. We all land at the bottom. F in AVF means foot, which is our left foot, inferior or below the heart. So if it's going to our foot way below the heart, it's going to be across the bottom. And 2, 3, and AVF all land at that left foot. And I know you're taking time writing this, so I'm just going to keep talking, and you can write and catch up as we go, or pause it if you need to. So V1 and 2 are located on the front of the heart, literally on the right side of the septum. Same with V3 and V4 on the front of the heart, anterior, on the left side of the septum. We drew a picture of that on our notes, so you can see where the line of the septum goes. And then 5 and 6 are literally located in the armpit, which is where the apex is located. Okay, so I mean, those are placed, V1 through 6 are placed exactly where they're picking up the electrical conduction from your heart. It's the first 6, all the limb lead ones, that are the only ones that talk to each other. So they talk to each other and then coincide with these leads. So if you need to pause this and continue writing, you can. If you are not quite sure what I said, you can rewind it and go back and take a look again. All right, so we're going to get into what's called artifact. All right, so artifact is actually, I think I need to move my face down. Artifact is actually something that happens on an EKG quite regularly, but you guys need to know how to fix it, because what it does is it makes the EKG look not normal, and it can be mistaken for different arrhythmias and stuff that they might have. So we're going to get into this 3 different types of artifact. We're going to get into those right now. So the term artifact just stands for like artificial. It means that the EKG strip, the readings, the little bumps, the PQRSTs are not coming from the heart. So that means they're not real. It's not a real heart monitor type reading. It can be caused by lots of different things. You just need to know where it's coming from, recognize what type it is, figure out where it's coming from, and then eliminate what's causing it. Okay. So it's typically easy to figure out. You just want to make sure that you don't have artifact when you've printed it out for your person, for your cardiologist or whoever's reading the EKG, because they don't want a false reading on the EKG. We want to make sure that they're just getting, they don't always know it's just artifact, okay? Because it can mimic arrhythmias and other abnormalities. All right, so the first type is called muscular artifact, and my face is going back up here again. All right, so muscular artifact. It sounds exactly what it means. It means exactly what it sounds like. So this means that the artifact, the little wiggles on the EKG themselves, are not coming from the heart. They're coming from movement of muscles. Okay. So it's muscle tremors. It might be muscle noise. It might be someone sneezed. It might be someone flexing their feet, someone with Parkinson's disease, someone that can't sit still. Lots of different reasons why you would see some sort of muscular artifact. Okay. So this is what a muscular artifact looks like. We see a lovely PQRST coming in a regular rhythm. It looks beautiful. And then we see blah, blah, blah. That's the scientific word, by the word. Blah, blah, blah. It doesn't make any sense, right? So that you can't see the PQRST. The doctor can't read that. They can't see the P to R interval. They can't see anything that makes any sense. This is kind of what AFib looks like. It's a little more drastic than AFib, but it can be mistaken for AFib. So we don't want the muscle tremors. Okay, so how would you fix that? I have to think about it for a second. How would you fix muscular artifact? Bet you got a good answer. Yeah. For me, I would make sure, number one, that the patient is trying to lay still. If they do have a condition like Parkinson's, I would make sure that it's not on their shaky hands. Put it on their wrist. I would take it off the wrist, put it up to the shoulders. If they can't seem to keep their foot straight, they flex their feet, point, flex, wiggle their toes. Yes, even wiggling your toes can cause this. Move it off their feet, get it up to their thighs or up to their belly. Okay, so just kind of look to see where the tremors or noise are coming from, the movement might be coming from. And you say, are you laying still? And they're like, yeah. And you can tell they're not because their hands are moving. Even just like a little like fidgeting of the hands, if it's close to the hand, any muscle along here is going to twitch and move. It's going to cause a muscular artifact. So it's basically just trying to make sure that there's no muscle tremors happening. Okay, second type. This is called AC interference. AC, like alternating current, which means like when you plug anything into the wall, you're getting AC current. Okay, so it's also called 60 hertz, and it's usually caused by when you have all those EKG wires and they're all crisscrossed and tangled. That's one of the most common things that causes it. Cell phones that are close by, if they happen to have a cell phone in their pocket right next to where the wires are located, that can cause this. This kind of looks like a caterpillar. You can kind of make out the PQRST, but it's difficult to do any P to R intervals and things like that. Like it's not really readable. And you see this a lot too if a patient is hooked up to say like a ventilator, or their blood pressure cuff is on and it goes off, and it's an automatic cuff that inflates by itself, so it causes some vibration. Anything that causes some vibration that might be close to your EKG wires could cause this type of artifact. So you're going to have to make sure your wires are uncrossed, they're not tangled up. Anything that could cause vibration is moved away. Cell phones are clear, all of that good stuff. Okay. All right. Our last one is called the wandering baseline. Okay. I'm going to move my face again one more time. Hi, I'm down here now. Okay. So, wandering baseline is, notice that it's not straight across like we like it, not on that nice straight isoelectric line. It looks like it's kind of going up and down like a roller coaster, up and down, up and down, up and down. Why it does this is it kind of just mimics breathing patterns. And it's like when they take a breath in, it goes up, and when they release the air, it goes down. Okay, so this is usually caused by, once you have them hooked up, you don't let it kind of, I call it settle in a little bit. You need a minute or so for it to stop being kind of wonky. Also, if you take the stickers and you place them too close to the diaphragm, so does everyone know where the diaphragm is? I hope you had anatomy. Diaphragm is right directly under the rib cage, and if you place it on the diaphragm, it's going to catch them breathing in and out. Okay, so you want to avoid the diaphragm, and we've talked about this before when we did sticker placement. Make sure it's off the diaphragm so that you don't get this wandering baseline. Okay. So the other thing occasionally happens is the stickers become, they're not laying flat. So you could get this by them not laying flat as well. So all those things you can fix. Again, if you need to review anything, you need to pause at any time, do so, and go back and get your notes filled in. We're going to do some review now. You do have the review in your packet. So we're going to take some notes in our packet, some more on the review. All right, let's see how to correct artifact. Lots of different ways and reasons depending on what type of artifact it is. So you always check the leads first. Make sure they're actually stuck to the patient like they're supposed to be. The wires are in the right places and they're attached to the skin nice and flat. Okay, if it's not flat, if it's folded over or twisted in any way, you're going to get a weird reading in that lead. Make sure there's no extra wires hanging around, no cell phones in the way. Anything that can cause a vibration isn't intertwined with your EKG wires. Make sure your patient's lying still. I know sometimes that's hard to do. I do EKGs on infants. Yep, little baby infants. Try to tell them to hold still. They don't. They don't like you putting stickers on them because they're cold and they're all exposed. They're mad at me anyway. And then you try you want them to lay still, right? Yeah. You just made them really angry. I usually sticker them and wire them and then swaddle them so they can't move. The wires stay in place. It works out pretty well. Just again, make sure of any additional equipment that might be attached to them, blood pressure cuff, ventilation, anything that's going to cause some sort of vibration. They also wear, a lot of times in the hospitals, they wear those inflation booties that help with circulation. And when they're inflating, they go zzz, they make a vibration. So that does cause it also. If all else fails, it's typically the limb leads that you're having issues with. Okay, so if all else fails, take the limb leads off their ankles and wrists or lower arms and lower legs and move them into the modified position. So move it into the right underneath your clavicle and or on the belly. That usually relieves any type of, especially muscular artifact, if they can't keep one of their limbs, still or at all. Okay. Hopefully that made sense to you. All right, let's move on to review. I believe that's what I have next. Looking at my papers here. Yes, we are going to review. Here we go. Okay, let's take a look at this one. This EKG, number 1, can you find the artifact? So on your paper, you have the same one on your notes sheet. Find the artifact. That should stand out like a sore thumb. And circle your artifact. Okay, circle it. Once you've decided what type of artifact that is, write that down. What leads are affected? And then how would you correct this artifact? So take a minute. Let's go 30 seconds. First, circle the artifact. Determine what type it is. We have 3 to choose from. Muscular, AC interference, or wandering baseline. So which one is this one? The leads are easy to tell what it is because you can see what the leads, they tell you 1, 2, 3, AVR and AVL and AVF, V1, 2, 3, 4, 5, 6. Once you write down the leads are affected, how would you correct this? What is this causing this? All right, I'm going to pull my paper up so that we can do this together. Hopefully you've got it all done already, but you did it. If you didn't, it's okay. We're going to do this. We're going to finish it up together. All right, so this is your first one here. This one right here. So I'm hoping that everyone circled this. I'm assuming you saw this and was like, yeah, that's definitely artifact. And it's artifact because we don't see a regular PQRST. There's what I call caterpillars on there, right? So what type of artifact is this? If it looks like caterpillars and it's all fuzzy, this is our AC or 60 hertz, whatever you want to call it. That's your AC or 60 hertz. That means it's electrical wires crossed or whatever. So what leads are involved? We can see that it's lead 2 and 3. This is also lead 2. This is your rhythm strip at the bottom. It's 2, 3, and AVF. 2, 3, and AVF. We all know what lead they have in common. 2, 3, and AVF are all inferior, right? They go to that left foot. So how do we correct this artifact? That left foot or left leg limb lead, that's a lot of L's, is probably whatever is causing this artifact, it's located near that sticker. So we're going to go directly to the left foot and look to see what is wrapped around it. It could be the cell phones down that way. Maybe you put this on their thigh and they have their cell phone in their pocket. Okay. So the reason I went to the left foot lead, I know it's that one because 2, 3, and AVF all go to the left foot. We just learned those regions. So since they're going to the left foot, this is the culprit that's causing this AC interference. You know what? It's probably the booty inflating. The leg booty. The boot that inflates to keep circulation. I realized it didn't sound quite right when I first said it. Okay. Hopefully you got that right. All right, let's move on to the next one. Okay, same thing. Find the artifact, circle it. What type of artifact is that called? Which leads are affected? And how are you going to correct it? Take your 30 seconds. I should sing the do 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 do. You don't want to be bothered with that. It's okay. I'm doing it in my head. Are you doing it in your head now? Okay, so hopefully you've at least circled the artifact so far, yes. And figured out what type it is. Okay. So I'm going to switch on over to my paper. We can do this together. I'm going to use my blue one this time. All right, so here it is in all its glory. So these all look pretty good till I get to here. Then I got some wonkiness going on. I also see it here, a little bit here, right? You see the like up and down wave, up and down, up and down. This is mimicking breath patterns, right? So this was considered wandering baseline. Let me get my other paper where I actually write the notes down. So they were all on the same page here. You had to circle all that stuff, but then to write your notes is on the next page. All right, so what type of artifact? If it's going up and down and wavy like this is called wandering baseline. So what leads are involved? You can see that V4 is, V6, and it looks like AVF. Maybe a little bit of V5's okay. But you can see it's all kind of down in this area, right? V4 and 6 down here near the diaphragm, near the bottom of those rib cage, right? So how we correct that? We're going to move off diaphragm. So we got to move those stickers off the diaphragm. They're probably too low. V4 and V6 should be up in that fifth intercostal space. So they're probably just located a little too low. And AVF, being a foot, our left foot, could be placed on the abdomen versus the leg. So that might also be just a little too high and too close to the diaphragm. That's why AVF would be doing that. Okay, so moving those stickers off the diaphragm, or at least checking the ones around that area to see if they're laying flat and all that good stuff. Okay. All right, you're doing great. We got 2 more to do. Okay, same thing for this one. Find the artifact and circle it. Name what type of artifact this is. The leads that are infected. Now notice that this is lead 2, but this is also lead 2. Her rhythm strip is lead 2. So you don't have to write that twice, obviously. This is lead 2. This is just lead 2 extended for 10 seconds. 2, 3, AVF, AVL, all those. So you got the leads that are affected. Did you figure out what type of artifact it was? Lastly, what do you think we could do to correct this artifact? This one would definitely look kind of like AFib to our docs, by the way. In these leads anyway, but not over here but if they just looked at the rhythm, they might consider that. All right, let me put my picture up too. We can do this together. Okay, here it is right here. It's the green one this time. So circling the artifact, I definitely see it here, here, and here. Maybe a little bit here. But this is definitely lead 2, 3, and AVF, right? 2, 3, AVF. And this type of artifact, this is that muscular artifact. The tremors, right? So again, all of these 2, 3, and AVF all land at the foot. So it's probably somewhere on the left foot that this person can't hold still, or it's in a place where they're wiggling. They don't realize it. Maybe it's on their ankle and they are wiggling their toes or whatever. Okay, so how to correct this is we're going to have them lay still. Hopefully that works. If that doesn't work, laying still, we may have to move it to a place that's not moving or not prone to movement. Most Parkinson's people, again, if their arm or leg is moving, they really don't have any control over it. You're going to have to move it off that area. This is definitely a muscular artifact. You literally cannot read my handwriting. Muscular. That was terrible. 2, 3, and AVF. And we're going to try to get them to lay still. If they can't lay still, then we've got to move it off the area that's having its own tremors, like the Parkinson's area. Okay? 1 more to go. All right, this one looks weird. See if you guys can figure this out. Okay, see if you can find the artifact. Determine what type of artifact that is. What leads are affected, and how would you correct this? And cue the Jeopardy music now. Do 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 do. I'm not going to torture you. Out here killing it, by the way. You're doing great. Keep it up. Keep being awesome. So we are going to have a quick review on this when we see each other next class. Just a quick review. Hopefully you understood everything. We'll talk a little bit more about it. You can ask any questions you might have from this lesson when I see you in person next class. Let's move on to this last one here. Here it is. All its glory. All wiggly wobbly. Well, this one right here, lead 3 looks just fine. Lead 3 looks great. 2, and is this lead 1? Does that say lead 1? It does. 1 and 2, not so much. I don't know why this is backwards. Anywho, these 2 do not look great. This type of artifact, there isn't a specific name to it. Part of it is definitely wandering baseline, because you can see it go up and down, right? And part of it is that the stickers probably aren't attached properly. Okay? Which comes along with wandering baseline. So it may or may not be caused by them breathing. It may be caused by the stickers not being adhered properly. But it's called wandering baseline because it doesn't go straight across. It's going up and down and up and down. It doesn't look exactly like the one we looked at before as far as the breath patterns go, but it's still going up and down, up and down. We don't have a straight across isoelectric line. So this is considered wandering baseline. This is a different version of one. So how do we correct this? Guarantee it's the stickers. Stickers need to lay flat. If they are not laying flat, you need to lay them flat. And if they're all laying flat nicely, then it is perhaps a little too close to the diaphragm. So you'd have to check that, because this is a wandering baseline. Does that make sense? Hopefully that does. Go back and rewatch any of this at any time. I think we are wrapping up. Yes, we are. So that is it for today, for our lesson today. So I will see you guys next class. Again, if you have any questions before next class, you can certainly send me a email or a text message, and I'll get back to you. And if you can wait till our next class, then just wait. Otherwise, you can also rewind this video, go back to the places you had questions about, rewatch, and fill it back in. And I will see all you guys next class. Have a great day.